So lots of new things to look forward to this academic year. And I thought I'd start out, in part because nobody volunteered for today. So I thought I'd start out with a little review of the evolving treatment landscape in advanced prostate cancer, and really focusing on the way that advances that usually gain footholds in more advanced disease, metastatic disease, are moving upstream, and how we as more regional therapists can capitalize on these and other convergent advances to, I think, improve outcomes in high-risk localized prostate cancer, which are the lethal forms of cancer caught early. And I think collectively, by improvements in early detection, risk stratification, technique, and integration of multimodal therapies, these are accounting for significant improvements in survival and decreasing death rates that we've witnessed over the last 3 decades in prostate cancer. We've had close to a 50% reduction in death rates from prostate cancer since the 1990s. And so I just want to walk through, I think, some of these advances, starting with, of course, diagnosing prostate cancer early. And that involves PSA, the best tumor marker we have. It has to be used correctly in the right population along the left side there, but increasingly now integrated with MRI when it's borderline elevated. And when used in combination with PSA, if you have a high enough PSA greater than 15, you can go straight to a biopsy. But if your PSA is borderline elevated, you get an MRI. If the MRI is suspicious, it allows for more accurate biopsies and a decreased diagnosis of low-risk cancers, but an improved sensitivity for clinically significant cancers. But of course, if the MRI is negative, then you can avoid a biopsy in up to 40% of patients. So this is an important paradigm that helps to continue to evolve PSA, which was being threatened to be thrown out like a baby with the bathwater because of its tendency to overdiagnose and lead to overtreatments. But of course, with a better understanding of risk stratification, which I'll get into soon, we now are able to uncouple diagnosis from treatment more safely with active surveillance, with intermediate risk as needed, treat, and of course, with high-risk disease, intervene with more multimodal type therapies, many of which are improved upon by the earlier and upstream migration of ADT-paced doublets and triplets. So again, that's where early detection with MRI imaging has been key. The year-end speaker this year is going to be Mark Emberton from the UK, who's helped to really develop, amongst others, like Samir Taneja, Rob Ryder, the role of MRI in early detection of prostate cancer. Coupled with this is a better understanding of risk. 30 years ago, we didn't really appreciate risk that much and didn't spread it out across the entire spectrum of the disease. Prostate cancer is arguably the most diverse genomically and from a natural history perspective of all cancers that humans can get, from very indolent to very aggressive. And so it's important to segment that risk. In the past, it was things like Parton's tables, D'Amico criteria. These morphed into continuous scales like nomograms, and now more recently, increasingly consensus segmentations, most commonly the NCCN with high risk and very high risk. But these are challenged for various reasons, in part, I think, because of the use of a digital rectal examination is a key reason, but underpinned by the fact that multifocal multiclonal origins create this spatial heterogeneity, which is difficult to quantify. And we've had imperfect imaging and undersampling, which again has in part been improved by the MRI and more image-guided sampling. But we also have to recognize that T-stage is highly subjective. What we feel and categorize as a T2, another person may categorize as a T3, or a T2A versus T2B in the D'Amico criteria, that all of a sudden put them into a high-risk category. Makes no sense, right? So we have to be able to have more objective criteria to segment people to better predict. But ultimately, there's also grade-defined issues. If we call a low-volume GG4, a single biopsy of 4+4, is that worse than a person with 8 cores of 4+3? It is if you consider one's a GG3, the other's a GG4, and yet it doesn't make sense. It's all about volume of pattern 4 and volume of pattern 5 in our needle biopsies. And again, how imaging is helping to get better biopsies, but also now how PSMA PET is helping to better define true or more sensitive local versus or non-metastatic versus metastatic disease. So all these things are helping to better define risk. And this is how I tend to think about it. Not that this is something that is out there, but it's a spectrum of disease from the very low risk through to various low and high tier intermediates to various low and high risks, which are defined by T stage, N status, M status, a volume of Gleason grade, and the grade as well as volume of Gleason grade and PSA. So collectively, all these, depending upon which risk factors you have, help to better categorize somebody who's truly low risk versus varying degrees of high risk disease. So that's the way I tend to try to capture risk. Of course, this is also captured in part by nomograms, but nomograms don't capture all this information going forward. So I think that early detection and risk stratification helps us identify those who should be treated and better identify risk with that disease of treatment success or treatment failure. So technique has also evolved a lot over the past few decades, and this is just an example, whether or not it's an intervention with surgery, which includes some focal therapies, again, highly selective, they're fine, but in general, they work well in people who perhaps don't need treatment. Whereas surgery has evolved through to an anatomic approach, whether or not it's open or robot assisted, it's the same operation done through different ways. And similarly, radiation has evolved through to conformal 3D or brachy approaches. So again, in both cases, we've had an evolving advance of technical intervention, which is reducing morbidity and to a certain extent, cost of intervention. There's high cure rates with monotherapy in low and intermediate risk disease, and similar types from a quantitative point of view of adverse events, right? The risk of impotence is about the same. With surgery, it occurs earlier. With radiation over the first 2 to 3 or to 4 years after treatment. And then incontinence, whether or not stress or urgency, is quantitatively similar as well. So again, you've got choices between these two, depending upon age, risk factors, etc. If people want to grab a cup of coffee, please go ahead and do so. Goal of therapy is, of course, to achieve optimal local control, rational use of multimodal therapy, and to minimize morbidity. The evidence would suggest that you need ADT when you use radiation therapy. Across the entire spectrum of radiation, ADT sensitizes and improves control, but there is no single optimal therapy. That if you compare both, they have similar outcomes, but you can't look at studies and compare BCR rates, biochemical recurrence rates, because of the temporal aspects of that change. After surgery, we detect PSA failure earlier than after radiation therapy. That creates an incredible effect on Kaplan-Meier projections over time. And definitions are different, with the Phoenix criteria rising above 2, with surgery usually above 0.2 or 0.4. And oftentimes there's early use of ADT, which compromises more clinically relevant endpoint ascertainment like metastasis-free survival. So you can't use PSA as a comparator. There are a couple of trials going on now, and perhaps the most important is the Swedish trial, SBCG15, where they're able to actually randomize their patients to either surgery or radiation therapy. That's probably going to read out in the next 1 to 2 years and give them some interesting higher level evidence to this very long-standing debate. In the meantime, there's been a lot of data bashing, looking at SEER databases, using things like propensity-adjusted analyses, which helps to better compare apples with other types of apples as best as you can. You pull together people with the same age, clinical correlative data, and then compare outcomes in terms of metastasis-free survival or overall survival. And there's a number of these, 6 with more than 10,000 patients, all of which, except 13, except for one, favor prostatectomy outcomes in terms of hazard risk of developing METs at 10 to 15 years and death from prostate cancer. But we also have to recognize that these have a systematic bias. There's an imbalance from confounding variables. People who have radiation therapy tend to be less optimal than people who have surgery. So there is this intrinsic confounding variable that we can't say as surgeons that this type of data demonstrates a benefit. There may be, if there is truly a benefit though, is it because one treatment is better than the other? Or is it because one has longer use of ADT and cardiovascular AEs that associate with it, or second malignancies from radiation therapy? And I include this study here because Marie-Pierre just got published in Journal Urology this past year, where we've looked at the BC data itself, 2,300 brachytherapies versus over 9,000 prostatectomies, median follow-up of 14 years. And this is the best data out there in the literature that quantifies over time risk of secondary pelvic malignancies at 15 and 20 years, about 2 times higher with radiation therapy compared to surgery. That's only a small relative risk and probably not enough to cause the differences that are detected when we look at SEER databases and propensity-weighted analysis. So I think there's other reasons for a potential benefit. And I think it's just because surgery defines extent of disease better, allows early detection of recurrence, and more options for salvage therapy. And that's what I want to move into now, is essentially integrating multimodal therapy in high-risk localized prostate cancer. And this is, again, like everything else, defining risk. Not all BCRs are the same. And we are now better able to define a low-risk BCR and a high-risk BCR, and better determine when and how to treat that recurrence. Low-risk BCRs, and this is all defined by this by actually a number of European urology publications, are defined by pathologic risk factors, timing of recurrence. The faster the recurrence, or if you have persistence PSA, that's worse than if the PSA starts to rise 4, 5, 8 years post-op. That just makes sense. As well, PSA doubling time is perhaps one of the most important determinants. A PSA doubling time less than or greater than 1 year seems to be an important cutoff. And so if we look at next the role of, what happened there now? There. Imaging is another way to better define or apply salvage therapies. But before that, I think I wanted just to point out that there has been a long debate over the use of radiotherapy post-surgery, which is beneficial. The question is, should it be adjuvant after surgery, not guided by PSA, or should it be salvage, meaning detecting PSA first, waiting over time, and then applying that therapy? I think that now there's several papers, randomized trials that demonstrate that there are similar oncologic outcomes if you wait and treat at recurrence with salvage therapy. It avoids radiotherapy in about 50% of patients. It allows time for functional recovery, which is very important. If you're irradiating in the first 6 months post-prostatectomy, it's going to interfere with functional recovery, continence, risk of stricturing, and erectile dysfunction. And it allows for much time to defer salvage therapy in low-risk BCR as well, and also increasingly now time to integrate with PET imaging. If you're going to apply salvage radiotherapy, most studies again demonstrate that it should be applied with androgen deprivation therapy as a sensitizer. So radiation monotherapy should be avoided. It's been shown to be inferior And the question is whether or not ARPI doublets, as opposed to just ADT alone, is superior, is a subject of randomized trials now. So this is, I think, how I envision sort of integrating multimodal therapy, the use of prostate-directed therapy, whether it's surgery or radiation therapy, and high-risk disease is beneficial and shown to be life-prolonging. Integrating systemic therapies, which we'll get to, may provide additional benefits as well. And then there's metastasis-directed therapy. And I'll just discuss very briefly, I think, how PSMA PET is allowing us to apply a more Holstidian approach to oligometastatic disease. In the past, our imaging criteria were not sensitive enough, lacked specificity. We were over-treating or under-treating if we were going after metastasis. PSMA PET is now allowing better selection of those who may benefit from the targeting of metastatic lesions. And this is an example of a patient of mine who was 50 years old in 2012, had a prostatectomy for a Gleason 9, organ confined, but N1 prostate cancer, had an early PSA relapse within the first year, treated with ADT plus salvage, no PSMA PET because it wasn't available over here. But he had a second PSA relapse within a couple of years of that, went to Heidelberg because, again, in Europe and in Australia, the access to these scans were available. And he came back with this singular lesion in the L5 Met. And that was then targeted. He was actually enrolled in a study called COMET, which I'll touch on briefly, in 2016, treated with targeted radiotherapy. And now, 8 years later, his PSA remains undetectable, even though he was recurring in 2016 with a rising PSA on ADT. So again, it illustrates that some patients identifying an oligo or solitary MET is going to affect natural history. Several trials are supporting this as well. This is one Canadian trial called COMET, which we were involved in here in BC, enrolled close to 100 patients with oligometastatic solid tumors, prostate, lung, some bladder, and some other solids. And they were randomized to remain standard of care plus or minus SBRT to the oligometastatic sites. And again, quite robust OS benefits, 17 versus 42% with the people who had SBRT versus not. Embedded in this trial were 16 patients with metastatic prostate cancer. Time to progression doubled, and OS was also significantly reduced in this small number of patients with prostate cancer. And so again, this data, a Canadian contribution, illustrates potential benefits of integrating metastasis-directed therapy into best supportive systemic therapies. What's the role of surgery in this? Certainly we can detect regional recurrences. They're accessible technically, and we've certainly embarked on this journey, like many others around the world, tempted to take them out because we can see them. And I'm not going to go deeply into this just because of, there's other things I'd prefer to cover and discuss, but we've reviewed about, I think over 50 cases here. In general, about 1/3 of patients had cancer and had a good PSA response, but 1/3 had cancer in the lymph node and had a poor PSA response, poor control, and 1/3 had no cancer in the resected tissue, and the PSA kept going up. So that's sort of the 1/3 rule applied to our experience here. The European collective is also kind of summarized in this European Urology paper here that Brignotti led. And similarly, there was enthusiasm that has since been tempered in terms of going after patients regionally with the salvage lymph node dissection. So my thoughts right now is that it's associated with durable long-term outcomes in only a minority of carefully selected patients. It should be limited to low-volume pelvic recurrences, preferably after failure with salvage ADT radiotherapy first. So I think patients with recurrence in the pelvis should be treated with ADT plus radiotherapy first. Good level 1 evidence that it benefits, and only in patients who recur or are not radiation candidates should we be offering them salvage lymph node dissections. It's difficult surgery. It can be adherent, and again, close to important vessels and nerves, and that the best outcomes are those who have delayed recurrences and usually combined with systemic therapies. The future, though, and this is something that Miles is now bringing as a trial here, it's already being looked at in places in Europe, especially in Oxford and in the Martini Clinic, is radio-guided salvage therapy using radio tracers or fluorescent markers that allow you to actually see or detect through audible signals regions where the cancer is, and allows you to go and localize and take it out. So these are continuing to evolve and be tested, and likely will be implemented regardless of the evidence, just because it actually has a number of attractions. And we can talk more about that in the Q&A, because I think it's of relevance to our population. So again, I've covered concepts around BCR on oncologic outcomes, a little bit about PSMA imaging to help refine a whole studying approach to oligometastatic patients and salvage treatments. And none of this, though, is really possible unless you improve systemic therapies. The analogy there is in testis cancer. Surgery for retroperitoneal metastasis would not be efficacious if it wasn't for really effective systemic therapies. The more we develop better systemic therapies, the more our regional therapies in recurrent high-risk disease may become a cornerstone of durable control. And so this is where improving upon ADT is important, because we know ADT alone is, while active, has its limitations for durable control. And so already we know that with ADT in the BCR rate or oligometastatic rate site, or even in de novo prostate cancer, the metastatic prostate cancer, earlier ADT is better than delaying. This was a debate for decades across the world, where there was a camp that said wait until metastatic progression or even symptomatic progression before starting ADT, because it didn't make any difference. But there are now a handful of randomized phase 3 trials that demonstrate the principle that treating at lower burden disease, when heterogeneity is less, leads to more durable control and improved survival. And whether it's a Messing paper, the TOAD trial out of Australia, and now more recently the EMBARK trial, which I'll come to. There's in this population of patients, intermittent therapy has been shown to be essentially, well, we call it non-inferior, but essentially equivalent to continuous. So in patients with BCR, non-metastatic or M0 disease, the approach is intermittent, not continuous, because it offers better quality of life, a similar control to metastasis progression and survival, and of course, less financial toxicity and side effects. So I think intermittent therapy is the standard, and this was, I think, demonstrated by a Canadian trial shown there in the New England paper called NCIC PR7. Again, just entrenching intermittent therapy as the standard in this population. But there's also now the opportunity to intensify ADT in this population with ARPI doublets, and that's the EMBARK trial, which was published in the New England Journal this past year. We participated in this trial, enrolled patients with a high-risk BCR, doubling time less than 9 months, but no metastasis. This trial actually had less, avoided the overlap of PSMA PET imaging and its ascertainment of MFS, but its primary endpoint was time to metastasis by conventional imaging. And there were 3 arms, standard of care, which was considered just LHRH alone, versus enzalutamide plus LHRH, or enzalutamide monotherapy. And this had quite a robust readout of benefit in terms of its primary endpoint. I'm just going to show this one slide. The paper is published. This just demonstrates MFS for the ENZA combo versus LHRH alone, a hazard ratio of 0.42 in terms of delaying time to MFS. That's an incredibly powerful benefit when you're considering that it was actually not compared to no treatment. Right? It wasn't compared to a placebo. It was compared to LHRH, which was considered and has been considered the best therapy for prostate cancer for decades. So again, adding a more potent AR pathway inhibitor here, an AR antagonist, better than bicalutamide. Again, it's just more potent, leads to better disease control. And even OS is trending with a hazard ratio of 0.59, low p-value, but that's still considered immature, and patients are still being followed for this. If you look at the graph for ENZA monotherapy versus LHRH, it falls in between these two. So you do lose potency if you use ENZA monotherapy, and it's associated with different set of side effects, principally gynecomastia, because of the increased conversion of T to E in patients on an AR antagonist. So I think that what this demonstrates is that patients with high-risk BCR, significant benefits with an ARPI doublet, and this is now approved across most, including Health Canada approval, but we are still waiting for funding of it. Actually, I don't even think, I'll have to think about that. I'm not even sure they're coming to Health Canada for approval because of patent issues, but it is being used, and I'm certainly trying to get patients on it in our clinic now. It also is a demonstration of the concept that moving a more potent therapy upstream, here the various doublets used in initially metastatic CRPC, moved upstream in metastatic castrate-sensitive prostate cancer, now moved upstream to high-risk BCR, are all demonstrating the same thing, that earlier use of a more potent ARPI doublet is improving survival across the spectrum of prostate cancer, which is illustrated here in terms of this graph just showing the treatment landscape of prostate cancer across the continuum. Of course, most new therapies are tested in second or third line CRPC because you can't have, if you're looking for OS benefits, you can't have confounding life-prolonging therapies downstream after that trial. And either way, once they get their footprint here, they move upstream into castrate-sensitive prostate cancer, metastatic, but now over time moved up into the BCR M0 space. And this is true for AR-targeted agents, taxanes, and other types of targeted agents, including PARP inhibitors, which are moving upstream as we speak, and PSMA lutetium, another agent moving upstream. So the question is to us as surgeons, if this path continues, what about the neoadjuvant space? Is there a role for using these agents neoadjuvantly? There already is, of course, with radiation therapy. It's a standard of care. ADT plus radiation leads to sensitization through a variety of mechanisms shown there. And even more recently, in a meta-analysis of the STAMPEDE trial, M0 high-risk cohorts treated with radiation plus ADT plus or minus ABI, the addition of ABI significantly improved disease control in the M0 high-risk state. One of the first demonstrations of better improved disease control, decreased MFS, when an ARPI doublet was combined with radiation therapy. And this is now a standard of care for this indication. What about surgery? So this is something that we've been very interested in here in Vancouver since the 1990s. We helped lead the 0 versus 3 and 3 versus 8 month neoadjuvant trials back then. We were all pleased seeing a 50% reduction in positive margin rates. And this turned out to be a pixelation problem. I'm glad to see John here, who's our token pathologist in the room to keep me honest. But ultimately, a lot of our reduction in positive margin rates was just the loss of pixelation. We're losing little microscopic foci at the margins and elsewhere that led to undercalls. Also, we used the wrong endpoints. We used biochemical recurrence rates. They were similar in both arms, but these trials were not selected for high risk. They were underpowered. We used the wrong endpoints. So essentially, all we can say is that we learned something. Then came the ARPI doublets, and these have been evaluated in a number of different centers, especially out of the Dana-Farber. We participated in some of these trials as well. Deeper pathologic response rates, yes, but CR rates remain the same. So the ability to completely eradicate the cancer with a more potent agent, a combination, remain the same, whether or not we're using ARPI doublet or a simple ADT. So, and ultimately very low, which I'll come back to. Either way, the improved depth of response and the benefits seen with an ARPI doublet in more advanced disease have triggered Janssen to move into a randomized phase 3 registration trial in the neoadjuvant space with high-risk localized prostate cancer. Over 1,500 men have been enrolled in this trial now. It's fully accrued and maturing. Likely we'll get some of the first readouts in 2025. And the main endpoint is metastasis-free survival, PSMA PET detected. So they had to actually shift gears in their proposal midstream to move from conventional to PSMA PET because it became a standard of care in so many other places. An awkward position to find yourself in for a $150 million phase 3 trial, right? Which is what this trial costs. If it gets approved, then again, our standard of care will change in patients with high-risk localized prostate cancer, and we as urologists have to become facile with giving systemic therapies, right? If we want to continue to be involved with these types of decision-making. If you look at the EMBARK trial, strongly positive, and project it to this, it's not. It increases the probabilities that such a trial will also be positive. But we'll have to wait and see. It has to mature for longer. We also looked at a ADT chemo doublet in the past, and the cheap article here back in the 2000s was the first phase 2 trial using ADT docetaxel doublets, helped provide feasibility for this North American-wide phase 3 trial called PUNCH. We enrolled 750 patients. It, again, suffered from the confounding effects of PSA-itis in patients post-surgery. People with very low early PSAs, especially in the US, went on to additional salvage therapies before the primary endpoint could be met, which was PSA recurrence. So 40% of these patients were non-evaluable because they were treated with salvage therapies before they hit their endpoint, which interferes with the robustness of this data. Either way, it's a JCO paper publication demonstrating a little bit of separation in terms of PSA recurrence and freedom from treatment failure, which is just defined as additional postoperative treatments in this cohort of patients. Probably not. It just hasn't been enthusiastic enough to represent a change in standard of care. But again, illustrates that benefits in metastatic disease are not being seen in the localized disease with these types of combination therapies. We led the molecular correlative studies of this trial. I only show this to demonstrate the variety of genomic alterations that exist in high-risk localized prostate cancer and the differences in expression profiles or RNA transcriptional profiles, pre and post treatment, which I'm not here to really talk about other than to show that this helps illustrate the ability to be able to do genomics on needle biopsies and post-treated prostate tissues. That's a technically challenging phenomenon because post-treatment we have small foci of cancer embedded within a lot of stroma. So it's difficult to get signal from noise when you're trying to extract small volumes of cancer cells out from a lot of benign tissue. But it's something that the field is moving forward with and is feasible now and helps set the stage for this idea, which is ultimately a biomarker-driven neoadjuvant trial where we know genomic sequencing enables matching of targeted agents to distinct molecular aberrations, despite improvements in survival with ADT or ARPI doublets in metastatic prostate cancer, complete response rates remain low. This differs from bladder cancer, where chemo gives a 30 to 40% response rate, or breast cancer. If you're a HER2 positive breast cancer treated with a PARP inhibitor monotherapy, you have a 50% complete response rate. And yet in prostate, we have therapies that actually have better disease control at the metastatic level, but we can't kill all the cancer cells, likely in part because of genomic heterogeneity and other levels of adaptive survival signaling. But this low CR rate provides a statistical opportunity to do a clinical trial where we can test whether novel combinations in a precision oncology framework can increase these complete response rates. So that's the background for the Genomic Umbrella Neoadjuvant study, which is now open here. And one of the reasons I wanted to present, because a lot of the residents and fellows are going to see these patients and get a better idea for the genesis of the trial. The trial primary endpoint is a pathologic complete response rate. There's patients who are eligible with very high risk, high volume, high risk disease, go on an 8-week master protocol. We get their biopsies for sequencing, and then based upon their genomic sequencings, they're assigned to now one of 4 sub-protocols. So you've got a genomically favorable subgroup, which are alterations that predict AR dependence, and they get randomized to either an ARPI doublet or triplet. If you've got a loss of a tumor suppressor like RB or P53 or P10, this is a aggressive phenotype cancer, you get randomized to an ARPI doublet plus chemo. So you're intensified treatment because these cancers are less AR sensitive. If you're DNA damage altered like BRCA, then you get a triplet with a niraparib, a PARP inhibitor. Or if you're an immunogenic cancer, high TMB, tumor mutational burden, you get addition with a PD-L1 inhibitor. And the statistics for the trial are just shown along the right side. This is just an example. We've enrolled well at only 2 sites right now, Vancouver and Toronto. We have over 100 here in Vancouver, just over 20 in Toronto, and now US sites are open and enrolling as well. But this just shows you the type of data that can be derived. This is an onco plot or print of just the DNA alterations, showing here the genomic alterations here. Each column is a patient. This illustrates the percent tumor fraction in the biopsy, the tumor mutational burden, which is high in those patients with a high MSI status, and alterations in genes like MSH. Only about 4% of those patients are like that, but it's organized according to alterations, for example, in S genes, in the SBOP genes, or FOXA1 genes. So this just illustrates how you can demonstrate this data in one dense plot, compare genomic alterations to P10 IHC status and how they align or not with genomic alterations, so on and so forth. And you can then go on from there and look at RNA-seq data. And this is only just from the needle biopsies. We haven't yet compared to post-treatment, which is the main aim of this study. This is just demonstrating feasibility with the first needle biopsy course. Again, just illustrating that there are actually some clustering of RNA pathways associated with what are called ETS gene alterations versus those that are SPOP related. I'm not going to get any more deeply into this, other than this can be mined extensively. People like Ewan Gibb, here Josh Squirrel, which is, where is he shown here, is a great postdoc in our group, helping to lead this kind of data analytics. And this does create deep insights into complex heterogeneous data sets. We're also looking at path responses and depth of path response. We've only had in the first 50 patients or 60 patients, 2 complete responses so far, 8 deep responses called MRDs with minimal residual disease. And you can sort of just see this histologically. This requires a path board review with several pathologists on it to quantify depth of response and what some pathologists call dead cancer with high degenerative scores versus very active cancers that are associated with bad cancers. And these are just a few examples of outliers of interest that you can get from these types of responders. This is a cancer that still looks, again, deep response, but a focus of very aggressive proliferative cancer here, here, and here, compared to here a case of a high degenerative score and potentially just a senescent dying cancer, still called a cancer, but it may be on its way out over the next 3 to 6 months or never recover enough to become metastatic. So these are questions that people like YZ Wang are looking at in model systems. Differences between dormancy and quiescence are important ways to sort of cytologically, morphologically help define survival pathways. And I'm going to miss that or forget that. So again, I think that I just want to end by, this is the last slide, the neoadjuvant model represents a window of opportunity study that allows us to study ways that cancer cells respond to, adapt, and potentially contribute to resistance in advanced cancer. And I bring this slide up because often whenever I ask this question to residents and even fellows, they oftentimes are not aware of the depth of biology known about treatment resistance. This is one of our main areas of focus within the prostate center, and in the prostate world around the world, acquisition of treatment resistance is the main source of grant funding. And in prostate cancer, it's driven by reactivation of the androgen receptor, which becomes genomically altered after we try to kill the cancer with AR pathway inhibitors. And despite the fact that the AR is never altered genomically prior to treating it. So this is, again, an example of Darwinian and selective pressures of treatment. We've shown in single-cell seq experiments and others that you never get an alteration in the AR until you perturb it with therapy. There are many other mechanisms of acquired treatment resistance that are in part genomically driven. There's crosstalk pathways activation across what are called RTK pathways, metabolic shifts from that's a spelling error there, from TCA cycle driven, OXPHOS to glycolytic and fast pathways. These are well recognized stress activated pathways, and so on and so forth, including an important concept of lineage plasticity. And that means that pathways that are shut off in adult cells, important in embryology, shut off in adult cells. When we knock down the androgen receptor, which is a differentiation pressure, these pathways are activated. And that's where alternative lineages emerge, principally in prostate, neural crest driven under genomic context, but enabled by AR pathway inhibition. And that's, again, where as we evolve guns, we're looking at new therapies to target these mechanisms of resistance. So as we and this year, we're opening up a 5th protocol here to target plasticity activated by ADT by targeting what's called EZH2, which is a modifier of the epigenetic pathways associated with and enabling lineage plasticity. So that's opening this year. And by the end of this year, hopefully Q4 or Q1 of 2025, the addition of capivasertib, which is an AZ drug targeting AKT in combination with an AR pathway inhibitor. Again, given that PTEN alterations are so common in prostate cancer and can be hopefully made vulnerable by targeting that pathway. And of course, this is where precision medicine and genomic biomarkers are in advanced disease already, metastatic CRPC, why genomics is so important now to identify those few patients who are able to get a PD-L1 inhibitor with high TMB, especially now with PARP inhibitors approved in CRPC, being used now, tested in castrate-sensitive prostate cancer. Same thing with PSMA lutetium. Again, a biomarker-driven, in this case, radioligand-directed therapy, but it is a precision oncology framework. And the AKT inhibitors are in phase 3 trials in CRBC, and hopefully we'll read out this year as well. Just examples of how our landscapes will continue to evolve in advanced disease, and these will move upstream over time. So I'll just end there by saying that I think that I gave this talk actually at the AUA last year. This was sort of one of the messages, because Whitmore always said that is cure necessary when it's possible, and is it possible when it's necessary? I think that by evolving many tools, not just surgery, but using early detection, risk stratification, better techniques, and ultimately integration of multimodal therapies, we can cure those patients who need cure over their lifetime. So I'll end there, and hopefully we still have some 10 minutes for discussion and questions. So thank you everybody for listening, and welcome questions.